Care power of attorney can appoint a healthcare proxy to make medical care decisions according to the instructions in your living will form. So there will be a form kind. A will, and what is the difference between a living will and a will? A will has no legal impact until after you are dead. So a living will is something you are unable to express, but it is going to work when you are taking the treatment while you are at the hospital or at home. And a will is only executed after your death. So living will, on other hand, takes effect while you are still alive. So here are the 10 most important needs. So you see, like, we had an idea, I think, like when someone is sick, we just transfer them to the hospital, the care is there. But we don't really see what are the, that is the relationship between the physicians and the patients only there. But with the family, what are the family needs? These are the things that what we really want, that we want to be with the person, to be helpful to the dying person. Like when my father was admitted in the ICU and then sometimes he goes to the HDU, they had these restrictions, I couldn't go. There were time limitations. But I really felt like going to him, nursing him, but that I couldn't do. So to be helpful to the dying person, to be informed of the dying person's changing conditions, to understand what is being done to the patient and why, definitely I didn't have that opportunity. But when I really wanted to know the updates was not really being provided to me. So to be assured of the patient's comfort, to be comforted, which I really didn't have, to ventilate the emotions. Okay, to be assured that their decisions were right, to find meaning in the dying of their loved one, to be fed, hydrated, and rested. So there are issues affecting end-of-life care. Critics argue at times that embracing end-of-life care is similar to abandoning patients. So you see there are arguments regarding that. A narrow-minded view, we feel, similar to the belief that length of life is exclusive metric of physician success. Embracing end-of-life care is no way similar to giving up on patients. Mind it, it's not giving up on patients. Rather, it complements existing treatment protocols. If treatment fails and a patient is still terminal, appropriate end-of-life care should be an option presented for serious consideration. The patients need to know they have the right to choose between extending treatment that could squeeze out a few more weeks or months of survival but have serious impact on quality of life, or to elect end-of-life care designed to improve quality of life towards the end. While patient autonomy is acknowledged as a key cornerstone of medicine, it has fallen by the wayside where end-of-life care is concerned. Most often, patients have neither explored the needed for planning for their death or nor are fully informed about the consequences of the medical interventions. So this is the thing that we have to embrace, not only embrace the death. I mean, embracing is not approaching to the death, but talking about it, how if death is imminent, how we should be dealing with that. So these things should be more focused, more talked about. So these are the quality standards for end-of-life care which we can provide in the hospitals. But this end-of-life care, up to now, it is only oriented in the hospital sector. You see, these are the 4 things that is oriented into this end-of-life care dimension. That is the hospital, the staff, the patient, and the family. These 3, the hospital, the staff, and the patient, are definitely oriented, but we have not yet considered the family values regarding this end-of-life care. So Dame Sanders, the founder of modern hospice movement, she was a nurse, and she felt it, and she founded one hospice center, and she said, you matter to the last moment of your life, and will do that we cannot only to help you die peacefully, but to live until you die. So conclusion, Bangladesh faces huge unmet needs of patients with life-limiting illness, where it is about achieving the highest quality of life and promoting comfort and self-respect for patients with not only incurable but also life-limiting diseases. End-of-life care promotion has been strengthened by announcing that allocation of end-of-life care is a human right. To overcome the barriers to successful implementation of end-of-life care, we need continued efforts, and it is our not only ethical but also a moral obligation to do whatever we can. So the changes being sought are in your awareness, your attitude, your skill, practice, and in your organization. So I have a challenge after my presentation. So what do you really want? A curative versus comfort with you, right? Thank you.
Thank you, Dr. Shahanaz Chowdhury. Due to time constraint, we'll take questions after finishing our second speaker.
I think we can take this and let her go, Take the questions first.
Questions?
It's better that you take the questions straight away.
Yeah.
Okay? You have any question?
I am Dr. Hassan. I work in pediatric intensive care, related to me. So I just want to know about do we have any guideline or rules regarding do not resuscitate in hospitalized patients in critical cares?
As far as I'm concerned, because I'm going through all these papers, I already had a slide that regarding these guidelines there are, but the implementation there is none. Like I said that the end-of-life care, the patients are there, the staffs are there, the healthcare providers are there. The fourth step, the family orientation, which is that is not being implemented.
Okay, I've got a comment here.
Yeah.
Actually, this do not resuscitate. Apart from those four things you say, a legal framework should also be there. Because you do not provide CPR, then what happens? The patient dies. Someone comes and says, "Why didn't you give it?"
Yeah.
You say, "I didn't consider it okay." He says, "You can't do that."
Yeah.
So there should be a guideline that should incorporate the legal framework as well.
Yes.
As far as I am concerned, there's no legal framework working in Bangladesh.
Yes.
So that's, for a long time, I've been preaching that we should make it.
Yeah.
To the legal people.
Yes, yes.
And this legal awareness about these things, end of life care, and the patients who are aggrieved that, like you, that I was not given the proper end of life care to my father. I don't know, because only awareness, only skills, and only ethical thinking will not solve the problem. Now these questions arise. When a patient is on a ventilator, is brain dead, but the heartbeat is going on. Now there is not even a proper definition of death in Bangladesh.
Yeah.
Because once upon a time, the definition of death in USA was when there is a brain dead. It doesn't matter why, it doesn't matter whether the heart is going on or not.
Yeah.
But at that time, the British definition of death was different. That heart must stop to declare death. But later on, now they have joined the USA. I understand mostly because the organ donations and all these things, but now they have. But it is not defined here whether we should follow the brain death or heart stop death. So we do not know when the patient is dying and what. What we do now, we are unfortunately following our legacy to the British medical system that we actually follow till today,
Yes.
that heart must stop. And now if a patient is brain dead and declared as a brain dead, we cannot stop the ventilator. If the patient is a donor, doesn't come. If the patient is not a donor, even if the patient on economic grounds request us to discontinue the ventilator
Yes.
and let the patient hand over to them so that they can cremate it.
Yeah. That is.
But the problem is this, because then someone may come, the possibility remains, why did you disconnect it? You cannot do that by law. Show me where the law says you can do that. So I think a lot of things should be done. Only ethical awareness is not enough. So what we can do from this is, from the appropriate quarters to go ahead and make a legal framework so that we are protected from the legal harassments and we can do according to our skills and awareness.
Thank you, sir. Thank you for your comment. But from yes.
I have the second part of my question actually, sorry sir. Our scenario is actually a little different. So, many a times, patients' relatives ask us to do DNR, not to continue resuscitation, as they don't have capability to continue the high cost of the care.
Yes.
So this is a difficult scenario. What is the legal aspect actually?
This, from both of your comments, I would like to add that this our healthcare system was based on just like comprehensive healthcare. That is what I say. That is preventive, promotive, curative, and rehabilitative. Because now there are epidemiological transition. 3 kinds of diseases are coming up. There is communicable, non-communicable, and re-emerging diseases. These communicable diseases, non-communicable diseases are ending into the chronic stage, and this has arose this end of life care more burning issues. This is why the World Hospice Day, that is on 14th October last year, they have given the theme that nobody is going to be left suffering. And this year the theme, I'm so sorry, but the next theme is that yes, we can. That means people are raising these issues more. That means if we don't have this legal framework, I think because it is in the constitutions of this universal health coverage, we might have all these things.
I have a small addendum to what our Honorable Professor Chowdhury had said, but it's the other way around. It's the patient's point of view. And I have seen, and I have actually been involved in cases of my relatives where they were forced to go on ventilation. And they have said, don't put me on ventilation if I go into a coma. But the staff at the hospitals, these are private hospitals, they said, we will take out all the tubes and everything then. You take care of the patient. So this is something as the commercialization of this ventilation process goes completely against the ethical views of the palliative care and the patient's last wishes. So this is a forced thing on the patient relatives to spend at least 1 or 2 days to put the patient on ventilation. While the patient is dead, really dead, but they keep the heart going on with that. So we fought for my sister's mother-in-law because she was in a coma, and ultimately we went to the topmost person who looked after her for 8 years, and he said, to be very frank, even my own father did not allow, and I looked after your mother-in-law for the last 8 years. So though I'm not allowed to say this in this private hospital, but do not entertain this. Let her stay in the ICU without ventilation. And she died at 12 o'clock at night peacefully.
No, thank you. But I'll make a comment here that this should be done. We are not doing it. This is criminal. This is not ethical. I think this low point is that if I do what you say that I am doing and the other people doing, is criminal acts. These are not ethical, unethical acts. These are criminal acts. We are talking about what I should be doing. I intend to do that. And I am trying to do that. But I cannot do that really because it's not defined and my interest is not protected from the people. So we are in that area, not in the area where it borders with or crosses the border into the area of ethics, into the legal illegality. No. So that is one of the things. We must. What I propose here that only one lecture will not cover it. So why not let's propose that one day I will invite you to have a seminar, joint seminar here, discussing this issue.
Thank you, Dr. Shahanaz Chowdhury. Our next speaker, Dr. Tanmay Vishwas, lecturer, Department of Pathology, Greenlight Medical College. His topic is consideration in stroke patients. I request Dr. Tanmay Vishwas.
Thank you, Chair of the session, for giving me the chance to present my presentation. I'd like to welcome all to my presentation, which will be discussing about the ethical consideration in stroke patients. I'm Dr. Tanmay Vishwas. I'm the Secretary of Alumni Association, American University of Sovereign Nations. Today, I'll be discussing about the elements of informed consent, standards of competence for patients, and obstacles in stroke cases in the acute emergency department, and recommendations for informed consent in those cases, and surrogate decision making. Thank you. Let's see what are the elements of informed consent in acute stroke cases in hospital. When we consider about the ethics, we would think about three primary elements of consent. There's a voluntary choices that the patient need to be voluntarily active when considering a choice, and patient should be decisionally competent enough. And the physicians or the healthcare providers which will be providing the information to the patient, he or she should disclose the information incomplete. Let's discuss about the standard competence as per the recommendations. What is competence? In social term, sufficient ability to make choices, and in legal term, individual's decision-making ability to make the demands of clearly specified decision-making task. When we consider about a standard frame of the competence, we will consider some basic things. What the patients need to be able to do. Understand the information provided, appreciate one's own situation in light of the information provided, and reasoning of the information, and patients must express a choice. In case of emergency department in hospitals, a stroke is more or less an emergency case. There are some obstacles we will face when managing a stroke patients. These are emergency settings and neurological deficits that most stroke patients have, like aphasia. Patients most probably won't able to say anything, and time pressure. We need to get hurry when managing a stroke patient. So there are some interesting recommendations regarding managing the stroke patients, maintaining ethical guidelines. At first, I said earlier that we need to disclose the information. So when we will disclose the information to the patients, we'll consider some basic formulas, like how. We will deliver the information in highly structured oral presentation that will be delivered by the physicians. And Sometimes physicians may use visual illustrations or simplified consent form. What would be the properties of that information? Like the information must be brief, and it will highlight on the given information and about to be given information. The information will be consistent with the previous findings, and as we are having some time constraint, we will concise the information in case of emergencies. What will we include in the information? Explanation of the diagnosis, what the patient is suffering now, proposed treatment and possible alternative treatments for the patient, and benefits and risks of all treatment options that we are considering and discussing with the patients. For example, like we are disclosing information to the patients as intravenous thrombolysis in acute stroke is a risky treatment. Disclosing it is, we are setting the autonomy of the ethics, but we need to make it clear that it is the treatment with best outcome for the patient. When we are making it clear to the patient, we are making it life-saving. So we need to make all the parts of the information clear to the patient. Then after the disclosure of the information, here come about the capacity assessment, because patient needs to choose voluntarily what he or she is going to ask for. For capacity assessment, we will clearly state that we will state to the patient that patient is being asked to make a treatment choice, and we will evaluate simultaneously his ability to make the choice. We will ask the patient what he or she think about the treatment choice, or what her or his ability about making a decision, what he or she thinks about his ability. When the interview progresses, the physician will check the stability of that choice, whether it is still fixed or it altered from the initial choice. Whatever encounters we will face, we will document it down. For capacity assessment, it is recommended to take a highly structured format, and the format should include patient's knowledge of the evaluation, the information disclosed, the identity of the participants and others present during the disclosure of the information and capacity assessment, the physician's assessment of patient's decisional abilities, it will be discussed in the next slides, the length of time devoted to the assessment, the possible consequences of patient choice, the physician's explicit opinion about patient's capacity, and likely outcome of any legal inquiry into patient's competence. So here comes how the physicians will assess the patient's capacity, whether he or she can make a choice or not. First, we need to assess the ability to express a stable choice. So we will ask the patient about the treatment option immediately after disclosure of the information. And as the interview progresses, we will ask again about it at the end of the whole session and interview. Secondly, as we need to evaluate the ability of the patient to understand what I am saying, we will ask the patient to paraphrase what is just said in his language. Thirdly, we will try to assess the ability of patients to appreciate the personal relevance of information provided. Like, we will ask the patient what he or she thinks about his current status, what she or he believes about his current physical status or disease. We will ask about his or her foresee, what he thinks as the consequences of his decision making. And lastly and fourthly, we will try to evaluate the ability of reasoning. That's why we will ask the patient to describe the flow of thoughts that led her to the final decision. Like, what he first thought about, then secondly what came into her mind, and thirdly what he again thought about, and the flow of thoughts that made her or him finally come into a decision. The physicians, when judging the logical flow of thoughts, he or she should avoid judging the final decision. He or she can only judge whether the thoughts flow is logical or not. But to avoid the bias, the physicians should avoid judging the final decision. But in case of stroke patients, most of the cases we find that patient is unconscious or patient is incompetent by the capacity assessment. The patient is incompetent of decision making because in stroke cases, patient have some neurological deficit. So we would go for alternatives in that case of delayed informed consent. The first one is living will, and second one is surrogate decision maker. Living will is extremely rare in developing and underdeveloped countries, but surrogate decision maker is often practiced. Living will is kind of thing like a written consent. When the patient was healthy enough, patient had written down someone's name who will take the decision on his behalf when he or she will be in end of life care. This living will thing is extremely rare to be found, but if it is found with a patient, then we will consider the written instruction of the living will. The alternatives of direct informed consent, second one is surrogate decision maker. In surrogate decision maker, what is it? Surrogacy is, in short term, it's a proxy. A surrogate is an advocate for incompetent patients. If a patient is unable to make a decision themselves about personal care, some agent or appointed person must make decisions for them. When? It would be needed when patient will lose capacity permanently or temporarily. And patient's incapacity is confirmed after the structured assessment of a physician, which is the specialist, most probably the psychiatrist is preferable here. If surrogates are needed, who will be preferred? Patients, at first we will look for the patient's written instruction, whether he or she had mentioned anyone's name. If not, then we'll follow the next to kin who comes more close as a relative to him, like guardian. We'll consider guardian, appointed guardian. Next we'll consider a spouse, then adult son and daughter. Next parents, then siblings, adult grandchild, and close friend. On the data of a review, systemic review and meta-analysis, it has been found that surrogate decision makers have 58% accuracy with the presence of preference of the stroke patients. Like when the unconscious or incapable stroke patients become capable or conscious, we will take the decision from him again for research purpose or to cooperate with the previous decision that had been taken. And it is found that the surrogate decision and patient decision match only 58% cases. Finally, to sum up with the conclusion that stroke patients are much more common in acute emergency department or neurology department at hospitals. So physicians and healthcare providers always need to manage unconscious or mentally deficient stroke patients, which creates a challenge to mental ethical guidelines. So proper and specific guidelines would help them to take informed consent rapidly from the patients in emergency cases. And capacity assessment tools would facilitate clinical decision making. Appropriate ethical judgment is possible with the cooperation of physicians, patients, attendants, and other health workers. Here are some references. Thank you so much for your patience hearing. Thank you so much, Chair, for the session.
Thank you, Dr. Anwar Biswas. Now the floor is for the audience. I would like to invite questions from the audience.
May I ask the first question?
Yes, sir.
First of all, I thank you very much for providing, for giving that excellent presentation, and also providing us with some theoretical background and standards on which it's possible to develop something practical. This case, you understand that the way you describe these things are all true, admittedly, but implementing this thing in USA and implementing this thing in Bangladesh is a very different thing, because our doctor-patient ratio is 1:10,000, and that how much time you are giving each patient attendant to assess this, and then you decide what you are going to do with this patient. And probably not a psychiatrist, I think a neurologist and neurosurgeons are the persons we refer to examine these patients, not the psychiatrist, because they may come here and present. But do you think in the present context of Bangladesh, healthcare situation, doctor-patient relationship, and the patient attendance, educational level and cultural level, do you think it's really possible to make something out of it, and implement on this basis you have given?
Sir, thank you for your advice and suggestions, sir. I think at first we need to make a protocol for the hospitals according to the international guidelines and national guidelines, and protocols would be available in all the hospitals and the healthcare facilities. Then I think we would need to train the specialists of all facilities, especially the facilities and the specialists who would need to treat the patient who are mostly unconscious. They need to have a special training about the capacity assessment and all other things related to handling the situation. Then if we have the special protocol in the hospitals, how to manage and handle this kind of cases, I think it's more likely possible to. Yes, it's a matter that most of the time specialist attendants and.
Let me help you out to some extent. That what you have provided is all right. Listen, we can work on that, so that something can be made out of it. Now, it is dangerous, I tell you, that you make a protocol out of your enthusiasm. You are a young man. You make a protocol or make advocacy programs so that it is made. And that protocol is there and is recognized. You do not have the healthcare facilities to support that. Then the litigations will be more in number, you see. The one who is not giving it, according to that protocol, will be taken to the custody. But he doesn't have any support or facilities or setup or healthcare facilities. So I think this is one of the things that is good for our awareness. And the thing that should be done should be, the resource thing has come up earlier. This resource should be. So the capacity building should be there, both on this side, one on that side. Then we can address these things to the nicer proportions. But thank you. This was a very good. I enjoyed it. Thank you. You may ask other questions.
Is there any question?
থ্যাংক ইউ স্যার। স্যার আমি একটু বলতেছি, উন্নত বিশ্বে যেটা হয় স্যার, ওদের কনসেন্ট অ্যান্ড ক্যাপাসিটি একটা বোর্ড আছে। যদি কোনো সমস্যা হয় ওরা ওটাতে যায়, ডাক্তাররাও যায়, রোগীরাও যায়। যাওয়ার পরে দে ডিসাইড, এবং ওখানে মেইনলি এটা আপনার চিকিৎসার থেকে বেশি দরকার হচ্ছে লিগ্যাল ডিসপিউট, ওইভাবে তারা সলভ করে। আপনি যেটা বললেন স্যার, যে আমাদের ডাক্তাররা তাহলে এই অল্প সময়ের মধ্যে এতগুলো রোগী দেখে কিভাবে শেষ করবে, সেটার ব্যাপারটা হলো স্যার, অনেক আগে একটা স্ট্রোক আপডেট বা স্ট্রোক একটা ম্যানেজমেন্ট একটা বুকলেট বের করছিলেন, সম্ভবত আমি তখন অনেক ছোট স্যার বয়সে, তখন ওটা ছিল সম্ভবত বাংলাদেশ নিউরোলজিক্যাল অ্যাসোসিয়েশন বা এরকম নিউরোলজিস্টদের সংগঠন, যেটা তারা একটা ম্যানুয়াল আকারে ছোট একটা বই বের করছিল যে অল্প সময় আপনি স্ট্রোকের কিভাবে ম্যানেজমেন্ট দিবেন এবং রোগীর লোক কিভাবে ম্যানেজ করবেন। এটা একদম পেরিফেরি পর্যন্ত দিয়ে দেওয়া ছিল। এটা একটা সহজ বুদ্ধি যে আপনার যে ডিসিপ্লিনের, যেমন স্যার প্যালিয়েটিভ কেয়ার এখন বাংলাদেশে অলরেডি এস্টাবলিশ টেকনিক আছে, তারা যদি ছোট ছোট এরকম ম্যানুয়াল বা গাইডলাইন তৈরি করার চেষ্টা করে তাহলে প্রত্যেকটা জিনিস এভাবে সহজ করা যায়। এবং এটা যেটা হয় স্যার, অ্যাট দ্য সেম টাইম ইউ ম্যানেজ দ্য পেশেন্টের যারা অ্যাটেন্ডেন্টস এবং ইউর কমিউনিটি, তিনটা জিনিসই কাজ হয়ে যাবে স্যার যদি ওই অ্যাসোসিয়েশনগুলো একটু দায়িত্ব নেয়। আর সবচেয়ে বড় এই আজকে সকাল থেকে এতক্ষণ পর্যন্ত যে আলোচনাগুলো হলো স্যার, আমাদের বাংলাদেশের প্রেক্ষাপটে সবচেয়ে গুরুত্বপূর্ণ যেটা, যে বাংলাদেশ মেডিকেল অ্যাসোসিয়েশন তাদের একটা কোড অফ এথিক্স থাকার কথা। আমি এখন জানি না স্যার, আমি শিওর নাই, আমি যদিও লাইফ মেম্বার স্যার, আমি এখন জানি না যে কোড অফ এথিক্স বাংলাদেশ মেডিকেল অ্যাসোসিয়েশনে আছে কিনা, থাকার কথা। আচ্ছা, তাহলে সেটা অনুযায়ী বাংলাদেশ মেডিকেল অ্যাসোসিয়েশনের যারা ডাক্তার এখানে রেজিস্ট্রেড, তাদের ওইভাবে চলা উচিত। এখন তাহলে যখন সমস্যা হয় তখন সাংবাদিক নিশ্চয়ই বলবে না যে আপনি ভুল চিকিৎসা করছেন, বা রোগীর লোক বললেই হবে না যে আপনি ভুল চিকিৎসা করছেন। তাহলে আপনি বাংলাদেশ মেডিকেল অ্যাসোসিয়েশনের যে ওখানে বিচার দেন, তারা দুইটাই দেখবে, ডাক্তারের ভুল হলে তার শাস্তি দিবে, লাইসেন্স পর্যন্ত সিজ করা যেতে পারে। আবার যদি রোগীর ভুল হয় তাহলে বলতে হবে যে আপনারা ভুল করছেন, ডাক্তার ভুল ছিল না। when doctor acts on the best interest of the patient, তখন আপনি যদি রোগীকে মেরেও ফেলেন আপনি স্যার এর জন্য লায়াবল না। তো এটা আসলে ব্যাপারটা সবসময় লিগ্যাল ধরতে হবে না, এটা আমাদেরও কিছুটা প্রশাসন মানে প্রফেশনাল, আমাদের প্রফেশনাল কিছু ডিউটি আছে।
ওকে, থ্যাংক ইউ ফর রিমাইন্ডিং মি দ্যাট অ্যাকচুয়ালি যেটা হচ্ছে সেটা হচ্ছে informed consent now is being discussed in the old format. You know, the legislations have come up that signing an informed consent is not enough. There should be evidence that you train the patient or the one signatory sufficiently to accept that this signature, when he put the signature, he knew what he's doing. Even a video recording has been suggested. Now, where do you think we stand? I mean, you develop something and it's not easy and it's not difficult, because I have formulated this ventilatory acceptance form. I have myself. Nobody wants to sign that. What do? I mean, you just train them up. You make capacity building so that we can do it correctly in more numbers, and we can do that. But to whom you are actually giving the thing? He refuses to sign because he knows that if he signs, he cannot complain again. So you have said, okay, let it be there. So I don't even know when I'm putting a patient on ventilator because the patient is dying out of respiratory failure. He said, you do what you do. Why should I put my signature? So you train them. And this Bangladesh Medical Association, why not the ethical bodies? There are so many ethical bodies coming up and they're doing so. So public, what should I say, awareness. This sort of program should go on from both private side and public side. So they understand that if they sign, this is good for their own patient. Not to incriminate the doctor that I did not put my signature. Why put it on ventilator? Now he is dying, this you are responsible. Now sometimes the legal framework is not very helpful for this medical community. So sometimes they say, okay, you want it? I want it. Okay, I give it. So that is one of the more things. So it's not easy, I tell you, because you are telling it for now. I have seen it for 40 years now, critical care. And the first palliative care in Bangladesh was in BSN. He was my direct student, Dr. Nizamuddin Ahmed, Professor Nizamuddin Ahmed. We have had a long talk about those things. So these things should be spread. Only 6 palliative care units in Bangladesh. And now we advocate things like that, but we cannot implement it. with only 6 we cannot implement it in a whole country. So that is the thing. That we are now aware, that we now understand that we have to go for advocacy program, awareness and capacity building program, and recommend to the authority who are responsible to enhance the present situation of this medical science for updating the medical care, health care to the people, and updating the people also that they are going to get the, so in order to get the best out of the medical, they have got some responsibilities. So this is the ethics should take it to authority, public, and doctors also. Ethical people should come to us and say, you didn't do it right. Why didn't you do it that way? And let us face those and change our course. And that's the idea of the whole thing, I think. So maybe one day we will have, like I say, a full seminar where we'll have a whole day time and anybody can express his mind. You see? Just like that. Thank you very much.
Thank you.
Thank you, Dr. Tanmay Vishwas. Now I request our chairperson, Professor Chowdhury, for concluding remarks of the session.
Okay, I have spoken already, I think, more than what you have expected. I'm sorry about that. This is because I've experienced so bad things and good things in my life. A lot of people say, thank you, doctor, you couldn't have done better. You see, mother taking that 1.5 year dead child back from my ICU, saying, thank you, doctor. Crying and saying, thank you, doctor, you couldn't have done better. I've seen those things. And I've also seen those things that they come, like she said, that smash everything. You know, other patients are there, but they are doing that. So I've seen both extremes. So out of that emotion, I think I have already spoken much. I'm sorry if I didn't want to hurt anybody. Everybody, I appreciate everybody for starting to have started to think that these things should be changed.
Yeah.
I personally tell you in one sentence, I do not like what is going on from the medical doctors.
Yes.
So please help us. So let's help one another.
Thank you, sir.
So thank you. I thank the two presenters and I declare this session closed.
Thank you, sir.